Mrs. Johnson is an 84-year-old patient. She came in for pneumonia, but almost left with a broken hip. She's on 14 medications. One of them, prescribed months ago for sleep, is increasing her fall risk today. What if I told you that the most powerful thing a pharmacist can do isn't adding more medications, it's knowing when to stop them? Hey, I'm Dr. Nath Arua, a clinical pharmacist, and today, we're talking about how you can deprescribe confidently, safely, and effectively in the hospital setting. You'll learn the exact steps to identify high-risk medications, build a deprescribing plan, and get buy-in from the care team, plus how to communicate with patients and families like a pro. If you've ever thought, is this med really necessary? This video is for you. Let's optimize, empower, and deprescribe. Let's get started. Let's start with the reality that too often gets overlooked. 1 in 5 hospitalized patients is on a medication that may be doing more harm than good. That's not a fringe issue. That's 20% of our patients. Every day. Polypharmacy isn't just a long medication list. It's falls in the middle of the night. It's confusion that looks like dementia. It's readmissions that could have been prevented with a single intervention. That's where deprescribing comes in. Not as a shortcut, not as rationing, but as a clinical decision-making tool rooted in patient safety. Our goal as pharmacists isn't just to dispense medications. It's to make sure every single one has a clear purpose, a measurable benefit, and the lowest possible risk. Deprescribing helps us reduce harm, improve outcomes, and most importantly, enhance quality of life. Because every time we safely stop an unnecessary drug, we're not just reducing a dose. We're starting a safer path forward. Now let's break down exactly how to deprescribe, step by step. Let's clear up one of the biggest myths in healthcare. Deprescribing is not withholding care. It's not about doing less or giving up. It's not about saying, there's nothing more we can do. It's not abandoning a patient, leaving them untreated, or ignoring their needs. In fact, deprescribing is the opposite of abandonment. It's thoughtful, intentional, and deeply patient-centered. And no, deprescribing is not about yanking medications away without cause. We don't take meds away. We evaluate them. We listen, assess risk, review evidence, and act with precision. Deprescribing is clinical precision. It's risk reduction. It's personalized care. And yes, it's patient safety at its finest. Because sometimes, the most powerful medication intervention we can make is knowing when to stop. Deprescribing isn't giving up. It's showing up differently. Still with me? Good. Let's dive into the step-by-step approach to deprescribing, the safe way. Alright, step 1. Identify your deprescribing candidates. This is where clinical intuition meets structured screening. Start by scanning for the obvious risks. Age over 65, on more than 5 medications. That's polypharmacy, and it's your flashing warning light. Older patients metabolize drugs differently, and even the right medication can become dangerous with age. Next, think about why the patient is in the hospital. New acute illness like pneumonia, a fall, or sudden confusion. These are often triggered, or worsened, by medications. If a patient comes in with delirium or a hip fracture, don't just treat the condition. Ask, did a drug contribute to this? Then zero in on high-risk medication classes. Benzodiazepines like lorazepam or alprazolam, linked to falls and sedation. Proton pump inhibitors, often started, just in case, and never stopped. Antipsychotics, especially for agitation in dementia. and sulfonylureas like glyburide, dangerous in older adults due to risk of hypoglycemia. These medications aren't automatically bad, but they deserve a second look. And here's the good news. You don't have to guess. Use clinical tools like the stop-start criteria, the Beers criteria, or medstopper.com. These resources highlight which meds are potentially inappropriate and help you weigh risks versus benefits clearly and quickly. So remember, age above 65, polypharmacy, acute illness, high-risk medications, and evidence-based tools. That's your shortlist for Deprescribing candidates. Every day, on every floor. Now that you've identified the who, let's figure out what to deprescribe, and why. Step 2. Medication review, coming up next. Now that you've identified patients who may benefit from deprescribing, it's time to ask the most important question. Does every medication on this list still make sense? For each and every medication, go through this mental checklist. Number 1. Is it still indicated? Number 2. Is it helping more than it's harming? Number 3. And here's the human filter. If this were my parent, would I keep this medication on board? That third question is often the one that cuts through noise the fastest. Now back it up with data. Dive into the chart. Review recent labs. Check vitals, nursing notes, and progress entries. You're not guessing. You're investigating. Be on high alert for signs of adverse drug events, or ADEs. A patient who's suddenly confused. A fall with no clear mechanical cause. A creatinine bump that doesn't match the clinical picture. These might be your clues that a medication is quietly causing harm. Maybe it's a benzo started 6 months ago for sleep, or a sulfonylurea that's now putting a frail patient at hypoglycemic risk, or a PPI that's lingered long past its initial use. This step, reviewing medication rationale, is where your clinical judgment meets your empathy. It's where protocols meet people, where pharmacists move from dispensers to decision makers. So slow down. For every drug, ask 1. Why is this still here? 2. Is it worth the risk? And 3. Would I want this for someone I love? Remember, medications aren't forever. Neither is the risk they bring. You've done the detective work. Now, it's time to advocate. Let me introduce you to Mrs. Johnson. She's 84 years old. Lives at home, independent for the most part. Until this week. She was admitted to the hospital with community-acquired pneumonia. Nothing too unusual, right? But as you pull up her chart, you notice something. She's on lorazepam for sleep, glyburide for diabetes, and omeprazole for reflux. No red flags on admission. But then, she falls. Yesterday, she was found on the floor. Confused, bruised, disoriented. Nurses suspect delirium. She hasn't slept well. Her BP's been dipping. Time to look deeper. Lorazepam, prescribed months ago by her primary doctor. Likely for insomnia. But in this setting, it's increasing her risk of sedation, confusion, and falls. There's no current indication for it. And in a hospitalized, acutely ill 84-year-old, the risk now outweighs the benefit. This is a perfect deprescribing moment. As the pharmacist, you step in. You document the lack of indication. You recommend discontinuing lorazepam, or starting a safe taper if needed. You've just prevented another fall. Maybe even saved her independence. Mrs. Johnson doesn't know it yet, but that one intervention might have kept her out of a long-term care facility. That's the power of clinical deprescribing. And it starts with noticing. One med at a time. Next, let's talk about how to bring your recommendation forward. clearly and confidently, with the medical team. Sometimes the most dangerous medication is the one no one questions. Alright, you've reviewed the medications. You've identified the risks. Now comes the most important part, speaking up. Because deprescribing doesn't happen in isolation. It happens in conversation, multidisciplinary rounds. That's your moment. You're not just a quiet observer. You are the medication expert at that table. And your voice can directly shape safer care. Here are 3 powerful phrases that open doors, not shut them. There's no current indication for medication X. A calm, clinical way to flag unnecessary therapy. This may increase her risk of falls or confusion. Brings in real consequences, without blame. Can we consider tapering or stopping it during this admission? Collaborative, non-confrontational, and invites shared decision-making. When you combine evidence-based rationale with a collaborative tone, you're far more likely to get buy-in from the team. You're not just suggesting a change, you're building trust. Remember, physicians often want to deprescribe too. They just need clear, confident input from someone who knows the medications inside out. That's you. Make your recommendation actionable, specific, backed by data, and don't underestimate the power of professional curiosity. Most teams will say yes when they understand why. Deprescribing isn't a battle. It's a team win, one recommendation at a time. Now that the team's on board, let's talk about how to actually stop a medication safely. Tapering, monitoring, and building a clear deprescribing plan. Coming up next. Now that the team agrees, it's time to put your deprescribing plan into action. In most cases, gradual tapering is safer than an abrupt stop. Especially for medications that affect the central nervous system. Why? Because many drugs, like benzodiazepines, opioids, and certain antidepressants, can cause withdrawal symptoms, rebound effects, or even harmful discontinuation syndromes if stopped too quickly. Let's walk through a real example. Mrs. Johnson is on lorazepam 1 mg twice daily, and there's no current indication to continue. Instead of stopping cold turkey, we create a simple tapering protocol that respects her physiology and prevents withdrawal. Reduce from lorazepam 1 mg twice daily to 0.5 mg twice daily for 3 days, then reduce to 0.25 mg twice daily for 3 days, then stop. This approach is gentle, logical, and patient-safe. It reduces risk while building team and patient confidence. Now here's where you elevate your practice. Document everything. In your note, clearly outline 1. The reason for deprescribing. 2. The exact tapering plan. 3. What signs or vitals to monitor. And 4. Any follow-up needed, especially post-discharge. This isn't just box checking. It's creating a clinical roadmap for everyone caring for the patient, especially in the transition from inpatient to outpatient. And when you combine a solid taper plan with clear communication and thoughtful documentation, you don't just stop a medication, you start a safer future for the patient. Now, let's take it one step further. How to bring the patient and family into the deprescribing conversation with clarity and compassion. Remember, tapering isn't just about safety, it's about dignity. Now comes the step that ties it all together, educating the patient and their caregiver. Because deprescribing isn't just a clinical decision, it's a conversation. Start with a phrase that builds trust and reduces fear. Something like, "We're stopping this medication to keep you safer and avoid side effects." That single sentence can turn resistance into reassurance. Avoid medical jargon. Skip phrases like benzodiazepine withdrawal or PIMs per Beers criteria. Instead, say, this medication can make you sleepy and more likely to fall. It was helpful once, but right now, it may be doing more harm than good. If your patient has cognitive impairment, dementia, or delirium, include their caregiver or family member early. Explain the plan clearly and respectfully. Their support could make or break the deprescribing effort, especially after discharge. Use written materials when needed. Even a one-page summary that says, 1. What medication is being stopped? 2. Why? 3. How? And 4. What to watch for? Can make a world of difference. Give them something they can take home, reread, and even share with their primary care team. Most importantly, empower the patient. Ask them, how are you feeling about this change? Have you noticed any side effects? What questions do you have for me? When patients feel informed and involved, they're more likely to trust the process and stick with the plan. Because when patients understand the why, they're more likely to support the what, and that's where safer care begins. You've made the recommendation. You've educated the team and the patient. Now comes the part that too often gets overlooked: monitoring. Once a medication is reduced or stopped, it's not enough to cross it off the list. You need to watch closely for how the patient responds, both positively and negatively. Here's what to look for: withdrawal symptoms, agitation, anxiety, nausea, rebound insomnia, restlessness. These are especially common with medications like benzodiazepines, opioids, or antidepressants. Return of the original condition. Has the heartburn come back since stopping the PPI? Has their blood sugar crept up since stopping glyburide? Is there renewed shortness of breath after holding a beta blocker? Stay vigilant. But don't panic. Not all symptom return means failure. It may simply mean reassessment. And here's the good news. Look for unexpected wins. You might see improved cognition, fewer falls, better sleep, or less dizziness. Things that medications were actually masking. Document your findings daily. Note any symptoms, changes in vitals, nursing observations, or patient comments. Your notes should show a clear thread: what was stopped, why, what you're watching for, and what's happening now. And remember, be ready to adjust. Deprescribing is a dynamic process. It's okay to pause a taper, to reintroduce a medication temporarily, or to shift course based on how the patient is doing. This isn't one and done. It's clinical stewardship in real time. When you monitor thoughtfully, you're not just following up. You're leading safer care. You're the one who connects the dots between deprescribing and outcomes. Monitor like it matters, because it does. You've done the hard work: identifying, reviewing, recommending, and tapering medications safely. But now comes a step that's just as critical: making sure the deprescribing plan survives after discharge. Start with the basics. Update the MAR and discharge medication list. This may seem obvious, but too often, discontinued or tapered medications get re-added during the reconciliation process by accident. Clean, accurate medication lists help avoid confusion and prevent represcribing errors. Then, include the rationale for deprescribing in your discharge summary. Why? Because the primary care provider, or the next pharmacist or nurse, needs to understand the why, not just the what. For example, lorazepam tapered during admission due to increased fall risk and no ongoing indication. Patient monitored and tolerated taper well. That's clear, actionable, and defensible. Now take one extra, but powerful step: Close the communication loop. Call or message the primary care provider. If the patient is going to a skilled nursing facility or long-term care, notify the facility pharmacist. And don't forget the family or caregiver, especially if the patient has cognitive impairment, dementia, or won't recall medication changes made in the hospital. A smooth transition means everyone, patient, family, provider, and pharmacist, knows exactly what was stopped, why it was stopped, and what to look out for next. This is where deprescribing becomes part of safer discharge planning, not just a hospital-only event. Remember, discharge is not the end of deprescribing, it's the handoff. And you, as the pharmacist, are the one who ensures that baton doesn't get dropped. Let's be clear. Deprescribing isn't just about reducing medications. It's about reducing harm, preventing falls, avoiding delirium, saving lives. So the next time someone says, "We're just cutting back on medications," remind them, it's not about medication reduction. It's about risk reduction. It's about stopping the cascade before it starts. It's about protecting people who may not even realize they're in danger. You, the pharmacist, you are the medication expert in the room. You see the interactions, the duplications, the slow drip of side effects no one else notices. You are trained to ask, is this drug still helping, or is it quietly harming? So speak up, collaborate with your team. Educate your patients and caregivers. Back your recommendations with evidence and heart. This is what leadership looks like in modern pharmacy. Be the pharmacist who sees beyond the medication list. Who connects the dots. Who changes someone's story because you dared to ask, "Can we stop this?" Be the pharmacist who prevents harm. Be the pharmacist who saves lives. Because every medication you deprescribe isn't just a clinical move. It's a chance to protect what matters most, your patient. So, how do you know when a medication is inappropriate? What tools can help you decide if something needs to be stopped, tapered, or adjusted? Let's walk through 5 of the top resources every pharmacist should have in their deprescribing toolkit. First up, the Beers criteria. Published by the American Geriatrics Society. It's the gold standard for identifying potentially inappropriate medications in older adults. This tool gives you drug classes to avoid, flags high-risk combinations, and even highlights renal dose considerations, especially helpful in acute care settings. Next, the Stop-Start criteria, an evidence-based framework from Europe. Stop helps you spot drugs that should be discontinued, and Start ensures you're not missing medications that a patient should be on. It's especially useful for preventing both over-prescribing and under-prescribing, because deprescribing isn't about doing less. It's about doing what's right. Need a fast, user-friendly tool at the bedside or on rounds? Medstopper.com is a fantastic web-based app that helps you visually rank medications by risk versus benefit. It's based on Beers and Stop-Start, but it turns the data into an intuitive, color-coded tool you can use with patients or the team in real time. Bonus: it even offers tapering suggestions built in. Don't underestimate your electronic health record. Many systems now include medication reconciliation alerts, renal dosing flags, and even embedded deprescribing algorithms. These prompts can act as a safety net, especially during transitions of care, discharge planning, or when new diagnoses come into play. But the most powerful deprescribing tool of all, your clinical judgment, and your relationships with the team. Because tools guide decisions, but you make them. You know the patient. You see the lab trends. You've heard the caregiver concerns. And you know when it's time to speak up, even if the med's been on the chart for years. So whether you're using beers, stop-start, med-stopper, EHR alerts, or just your own seasoned judgment, remember, these tools aren't just checklists. They're how you translate evidence into patient-centered action. Alright, real talk time. Now we want to hear from you. That's right. Pharmacists, residents, clinical team members. What medications do you deprescribe the most in the hospital? Maybe it's those sneaky PRNs that never get reviewed. Or those sedating antihistamines that somehow keep sticking around in older adults' medication lists. Maybe you caught that duplicate therapy on a transfer order. Whatever it is, your insight matters. Drop your go-to tips or a quick story in the comments. Let's build a space where we can actually learn from each other's frontline experience. And hey, like this video if you've ever stopped a fall, a readmission, or even just helped someone sleep better by deprescribing smart. You're out there doing the work. Let's celebrate that. Share this with your pharmacy crew or clinical team. If you've ever had that, "Why is this patient still on this medication?" moment, they'll totally get it. Let's keep the conversation going, because the more we share, the better we all get at safe, patient-centered deprescribing. Thanks for patiently watching. I will see you in the next one.